Hello and welcome back. Thank you all for sticking with us. That was a great discussion that we had. And now we're ready to move on to our next panel. In a previous panel discussion we hosted this summer, Dr. Ana Maria Lopez said something that I thought was really profound. She said that COVID-19 has ripped the Band-Aid off in terms of our understanding and acknowledgement of the disparities in healthcare outcomes. This is not news to probably most of us here, but now that more people understand and are paying attention to the problems of inequity in healthcare. We have an esteemed panel to discuss equity in cancer care, and I'm delighted that our good friend, Dr. Otis Brawley, has agreed to be both panelist and moderator for this discussion. So I'm going to turn it over to you, Otis.
Hello. Thank you, Shelley. It's wonderful to be able to talk to you today a little bit about health equity and cancer. We have a wonderful panel today. In brief, I'll introduce them all now, and then we'll go back to each panelist to make an opening statement, and then we'll have the opportunity to take questions. Our first speaker is going to be Dr. Arnethea Sutton of Virginia Commonwealth University. Second will be Dr. Nadine Barrett, who's Assistant Professor of Family Medicine and Community Health and Associate Director of Community and Stakeholder and Strategy Equity at Duke University, Stakeholder Strategy and Equity at Duke University Cancer Center. And third will be Dr. Katherine E. Hayes, who's a medical oncologist and associate professor at the University of North Carolina Lineberger Cancer Center and chair of a committee at the American Society for Clinical Oncology that is very much involved in health equity. And so our first speaker will be Dr. Arnethea Sutton of Virginia Commonwealth University.
Thank you, Dr. Brawley. So I'm very excited to be with you all today. And so for some brief moments, one thing that I would like to discuss with regard to this idea of cancer inequity, cancer disparities, and our goal to achieve cancer equity. So the two factors that I really want to focus on as they are what I'm most passionate about is looking at this idea of cancer care delivery and psychosocial factors and how those both interplay when we're talking about cancer disparities. And so we all know that access is a huge problem with regard to getting cancer care, and huge just seems even inadequate of a term. But I challenge everyone to think about if everyone had equitable access and so everyone had insurance and they can get to care, would we see positive outcomes or great outcomes from everyone? And most of us on this call know that is not the case. So the work that we do in our lab, we're looking at how once people get to care, and then particularly we look at Black women because I do work with breast cancer. So once they're getting to care, they're having these issues with poor patient-provider communication, poor satisfaction, less satisfaction with the care they're receiving. And we're seeing, our work is showing, and the work of many others is showing that they have poor or negative outcomes with regard to quality of life, and then those cancer care outcomes. So the first I want to talk about is patient-provider communication. Many studies are showing that Black cancer patients report poor patient-provider communication than their white counterparts. And so many might be wondering, like, why does that even matter? Well, patient-provider communication does have implications for if people decide on certain treatment, if they get their treatment on time, if they're satisfied with their care, and even quality of life. So, for example, we've done some work, and under my mentor, Dr. Vanessa Shepard, we look at chemotherapy initiation. We've looked at adherence to adjuvant endocrine therapy. And of interest, we found that Black women are more likely to initiate chemotherapy when they report that they receive great provider communication. Of interest, though, it was the reverse for white women. So chemotherapy initiation was higher for white women that reported lesser satisfaction or lesser patient-provided communication. So the thought of that, which seems like very interesting, like these individuals have different thoughts. So that makes us think, and I think it should take us into the thought of looking at patient-provided communication and our interactions with patients the same way we do the idea of precision medicine modeling. So we think about precision medicine and we think about tailoring treatment and therapy for the individual. Well, I challenge everyone to start to think about that with regard to how we're interacting with patients and how that can have implications for better outcomes with patients. And so the idea of patient-centered communications, where we're thinking about patients' needs, values, and preferences, and how all of that plays into maybe their initiation of treatment, maybe their adherence to treatment, and other long-term outcomes. Also, we look at psychosocial factors. And so I'm very interested in psychosocial factors, namely because we see some of these like race-based discrimination within healthcare. We see medical mistrust. We see individuals' beliefs about their medication or their treatment. All are related to, one, their outcomes, so if we're looking at mortality and recurrence, but also related to whether or not they initiate treatment or adhere to treatment. And so work that we've done recently and that we were able to present at the AACR Disparities Conference showed that Black women tend to adhere to Black breast cancer patients tend to have lower adherence to the adjuvant endocrine therapy. And one of the factors that was most salient to that was their beliefs about medication. Well, further work showed that their beliefs about medication were also related to patient-provider communication. So we see how all of those factors kind of play together with regard to patients' decision-making, their treatment initiation, adherence, and other outcomes. And so, like I said initially, my charge to myself and to others is to now think about what we're doing with regard to cancer care delivery. So we want to get everyone to care, but everyone needs quality care, and not everyone needs the same care. Care absolutely needs to be tailored, and that goes beyond their therapy, but it also goes to patient-provided communication and to making sure that people have guideline concordant care. And even with regard to survivorship care planning, you know, my charge is to make sure that we're thinking about the precision medicine model and how we can use that model with regard to cancer care delivery.
Great, superb. Thank you very much. Now let's move to Dr. Nadine Barrett, who again is Assistant Professor of Family Medicine and Community Health at Duke University and the Associate Director of Community and Stakeholder Strategy and Equity at the Duke University Cancer Center. Dr. Barrett.
Excellent. Thank you so much. And it certainly is a pleasure to be here and to be a part of this important conference. It's also great to hear Dr. Sutton really share about access to care, because that's such a critical part of all that we think about and we do. And I'm going to talk a little bit about clinical trials, but kind of shed a little bit more into what Dr. Sutton has talked about, because she did a great platform for me. So thank you in advance for that. So really, just in general, we know that there are multiple factors that's impacting lack of access to clinical research and trials. However, what we don't talk about often is that the very same things that actually impact people not getting access to care are the same things that impact access to clinical trials. And so if people have a challenge with transportation to get to a trial, they're more than likely having a transportation issue in terms of getting access to their care. Likewise, if someone's having challenges as it relates to language, because things are not available in their language, or people are not available to even speak with them and interpret what they're saying in the communication between their provider, then that's going to be a problem and a barrier for participating in clinical research and trials as well. So I won't go too deep into this, but just really recognizing that access to care really does shape a lot. If you don't have access to care, the likelihood that you'll have access to clinical trials are pretty slim, or at least access to be able to be engaged or asked. This highlights some of the other factors that really are associated with access to clinical research and trials as well. And so we know for certain that there's a whole background around historical and current atrocities, systemic and structural racism that goes back over 400 years, and most certainly is very evident in our society as well today. And all of these factors together create trust and lack of trust. And I don't really like to use the terms lack of trust. I rather more use terms such as how can organizations be more trustworthy? And then that helps to kind of put the onus more on organizations versus putting it on the people to build their trust in systems that are not really supporting them, just as we heard from Dr. Sutton and the experiences with the outcomes that we're seeing. And so I really want to highlight a couple of things with that then, is that we most certainly have to think about those social cultural factors and the systemic factors as well. But I'm going to hone in a little bit more on more research that's showing up over time, actually related specifically to this concept of being interested in participating in clinical research and trials. So what we've heard and what we do know is that there's been a narrative historically that people of color, particularly African Americans, do not want to participate in clinical trials, concerns about being a guinea pig, et cetera. But really those terms we get it, but it's also kind of the superficial level of what really is the undergirding factors. And a big part of that is not trusting because organizations and systems have not historically been trustworthy. And what's even showing up more is that where we looked at a lot of data that have said they don't want to be a guinea pig, et cetera, I'm not trivializing those things by any means. In fact, when we talk about Tuskegee, those things are critical, they're real, and most certainly have an impact in other social systems today. But what we don't think about, what we need to think about more are some of the more recent compelling studies that's actually shown that African Americans and even some Latinos, Latinx are actually much so interested in participating in clinical research and trials if they were approached and got the information that they need so that they could at least practice informed decision-making around clinical trials participation. Now, this is important because when we talk about healthcare, access to healthcare, informed decision-making, we talk about this in every other area of cancer, and most certainly it fits within the context of whether or not someone decides to participate in a study or not. So here are some examples of studies that are starting to show some differences. One of them is my own study that was done with me, UCSF and Roswell. Together, we had a sample of over 4,000 participants. So we actually identified people who were most certainly interested. They just wanted to learn more. And likewise, in these two other examples here, Terry Albrecht also showed unexpected findings for African Americans that wanted to actually donate biospecimen and biobanking. And then another one that's actually more interesting, and I want to hone in on this one here. This is by Reagan Durant, one of our colleagues out at UAB. This study actually did something that we actually have a center at Duke called Reach Equity, which is specifically focusing on the patient-provider interaction and where bias may sit within that, right? And so in this context here is a study that Reagan and his colleagues did, and it was specifically asking 91 interviews across cancer centers in the United States and asking specifically what are the key factors associated with the ask, if you will, about participating in clinical research and trials by the research team. So now this is a systems approach versus trying to do interventions in the community. Both of them have an appropriate place, of course. So what he found was that the first was that minority participants were perceived to be challenging by these based on that qualitative interviews. Again, 91 interviews across cancer centers across the country. Potential minority participants were perceived to not be ideal study candidates, and this remained true even if they were actually identified as being eligible or for the study and to be able to participate. And then the last two pieces, I won't go into too much depth, but most certainly providers were withholding that clinical trial opportunities from people because they were concerned about them being ideal candidates. And then there's also this idea that race was perceived as irrelevant when screening. So we screen everyone, we don't think about race. And as we know that if you don't think about race within these types of contexts, you kind of can miss the mark in terms of really wanting to have the outcomes that we want, which is better outcomes for all. So the goal is ultimately that when we think about equity and increasing access to clinical research and trials, it is a health equity issue, and it's one certain thing that we focus on in the Office of Health Equity at the Duke Cancer Institute. So here I want to highlight a couple of important things and compelling things to be able to have a better sense, if you will, of the communities and people we're serving. So one most certainly is ensuring that as patient advocates, as people who are really committed to addressing issues related to survivorship, clinical trials being a key part of that as well, is ensuring that we're assessing and identifying the needs in our community and what our community's perceptions are around clinical research and trials. In that process of raising awareness around access, it's also important to talk about clinical trials at that point. So how can we advocate to talk more about clinical research, clinical trials during these types of conversations around prevention and screening versus bringing those up when people think it's a final option for them, which is oftentimes not necessarily the case. The other space is how do we advocate in terms of engaging patients and community advisors in research? These are two different groups that I work with. I have several community advisory councils I work with in multiple ways, but most certainly the idea was to ensure that patient advocates and groups and teams and even diversity and inclusion groups are engaged in such a way that they learn and understand and know more about what research is. We learn from them about where the gaps are in the education and the engagement in our communities and our patients. And ultimately, with with this process and ensuring that there's diversity, where they even get training around implicit bias and understanding what that means, what structural and systemic racism is, and how that plays out in healthcare as well. Here we have two examples where our advisory councils actually play a key part in our research studies as co-investigators, as and in one case as a co-PI on our research studies. And in this area here, the group at the bottom, they are actually a faith leader group. There's 16 churches in North Carolina, Amy Zion. We work very closely with them. And in fact, so much so that their goal is to increase African-American participation in clinical trials. Because of COVID-19, they've actually pivoted, and now they are actually paid partners in increasing engagement around education around vaccines and education around screening and testing for COVID-19 as well. Out of these 95 people that have been trained around research participation and research engagement and what that means in Research 101, 91% are actually serving as advisors, paid advisors, and experts in research. Also, when we talk about bringing research into the community, this is another space here with one of our community members. We actually started doing education in the community and really fought for thinking about what kinds of policies need to be made around stomach cancer in particular, and ensuring that people get screened for stomach cancer. What we learned here is that through this process, we actually took a clinical research study to the church and did it during midweek service, in which 92 African Americans participated in the study, which included blood draws and included an extensive questionnaire and a urethra breast test, which requires a swallowing of a specific solution. As a result of that, we also ensured navigation was included. Just as Dr. Sutton highlighted again, there's no use in clinical research and trials anywhere unless we're making sure that those who are underserved and carrying the greatest burden of disease do not get access to the care as well. And last but not least, I just want to highlight this key point is that we found in three different studies recently that where African-American men who were a part of a clinical trial here, and they all were metastatic advanced stage prostate cancer. In all cases, all three studies, they found that the men who were African-American went in with worse disease than their white counterparts. And yet at the end of it, they found that the Black men came out with better outcomes than their white counterparts. Again, just another example of when we don't have diversity in clinical research in our trials, we actually miss out on an opportunity that we miss discoveries or different potential ways in which people may respond to studies and drugs that we would not know if we do not have the diversity that we need. And last but not least, just ensuring that the work that we do, these are just some key recommendations, that we engage our patient advisory councils. We really think about implicit bias training and what that looks like on a national level, even in terms of thinking about what it would look like to have that training for every member of the research team and what that looks like. And also ensuring that we also create policies, if you will, that puts more teeth into accountability so that funding agencies can actually start to move forward in when giving funds, that those researchers actually have a proactive plan to increase diversity in clinical research and trials. There's a lot of other pieces I could mention here, but I'll leave it here for now and leave it for our discussion. And thank you.
Thank you. And our third talk is going to be from Dr. Katherine E. Hayes, who's a medical oncologist and associate professor at the University of North Carolina Lineberger Cancer Center. She is also the chair of the American Society for Clinical Oncology Health Equity Committee. Dr. Rita Hayes.
Thanks so much. So when I'm asked to speak on the topic of cancer care equity, I always have a bit of a dilemma because I wear a number of hats that intersect this issue. First and most importantly, as a breast cancer doctor and the leader of a clinical breast cancer program, with breast cancer being one of the disease types where we know there are substantial racial disparities in mortality that have been persistent over time. And then also as a researcher who's primarily focused on disparities and system level contributors to disparities in cancer. But the hat I decided to wear for this presentation today, and one I've been spending a lot of time wearing this year, is as the chair of the ASCO Health Equity Committee. And so I think many of us, some of us for years, and certainly many people in the audience here in 2020 have been asking, what can I do? What what actions can I take now that my level of awareness about these issues has been raised? And so I think as an organization, ASCO has been asking that question to some extent for a long time, but certainly a lot in the past couple of years, which is something that I am proud to be a part of the organization because of that. So in 2019, ASCO actually started revising our policy statement related to cancer disparities and health equity, and it was published in 2020, just as racial violence and discrimination were coming to the forefront of a lot of national conversations. And that document really focused on 4 key areas of recommendations for action, primarily within the organization, which is the largest advocacy organization in the United States representing oncology professionals. And those 4 focused areas for us are to ensure equitable access to high quality care, ensuring equitable research. And we actually changed this from a prior version that had said ensuring equitable access to research. Because as Dr. Barrett mentioned in her remarks, and as many of us I'm sure are aware, we don't only need to make sure that we get people to clinical trials, we need to make sure that we're designing and conducting clinical research that's relevant to the communities that we're serving. People will join research studies that matter to them and their community, that are addressing questions that are important to their health. If we're not addressing questions that are important to people, why should they volunteer to be our partners in research? So we changed that focus to some extent. We also included a new pillar in this update of addressing structural barriers to equity in cancer care. And then finally, of increasing awareness and action, not only within the organization, but also leveraging the organization's resources to increase public awareness and action. So that policy statement came out earlier this year and is publicly available. But what we're doing next that I'm really excited about is to turn that vision, that policy statement for where we think the organization should be active, into a strategic planning effort to say, okay, these are great ideas. What are the action items that we need to put on a list and hold ourselves accountable for to make sure that those ideas are turning into reality? And so we are partway through that strategic planning process right now, hope to have it concluded by the first quarter of 2021. And the 4 strategic pillars in this process, as you can see here in the diagram, are those 4 main focus areas from the policy statement. Another thing we have going on in the organization this year that has just been an exciting confluence is that our current ASCO president, Lori Pierce, has chosen equity as her presidential theme. So the ASCO annual meeting is held in June of every year, and each ASCO president holds a term of 1 year. And at the beginning of that year, in June of 2020, in this case, the president picks a presidential theme that they want to use the resources of the organization to promote and discuss over the course of the year. And then that will run through all of the sessions of the annual meeting, which has about 35,000 attendees annually. So Dr. Pierce chose equity, every patient, every day, everywhere as her presidential theme. And this is actually a slide that she loaned to me with her word cloud. She was very proud that she figured out how to make a word cloud. But this is a reflection of the conversations that she has had, that we have had with different stakeholders in the organization, that their reactions when they hear this theme, what comes to mind for them. So I think what you see here is that when you ask stakeholders who are providers and patient advocates what they first think of when they think about equity in cancer care, they think about a lot of different things. But to me, that is not so much discouraging as exciting, because it means that this is a multifaceted problem, right? We've already talked about this is not just at a patient level. This is not just at a provider level or a community level. It's also at a structural level. It's at a health system level. It's at a national and state government level. So I think having a lot of different voices within the organization who see this problem from their own perspective and think about the different levers that they have to affect change is actually a strength, although it's also a challenge to plug all those people into a process. And I think that's what strategic planning does for us, is to create very clear places where people within the organization who want to do something have a place to plug in. It's where we say, okay, you have this skill set, you have this knowledge base, you're a trialist, you're a health services researcher, you're a basic scientist, you're a busy clinician in a private practice. Okay, here's an initiative we have going on that you're a good fit for. Let's get you involved. So a few of the ongoing initiatives within the organization to make you aware of. Within the parent organization, ASCO itself, we have long been involved in policy advocacy related to care of our patients. And currently there's a large advocacy push related to House Bill 913, or the Clinical Treatment Act, which would make law something that perhaps many people aren't aware isn't already both law and common sense. And that is compelling state Medicaid programs to cover the routine costs of care for patients who are part of clinical trials. This is not the cost of the trial. This is not the cost of the treatment on the trial. This is the cost of the things that this patient would be getting, whether they were in standard therapy or on a trial. Things like blood draws, visits with their doctors, CT scans, things that Medicaid would be paying for if the patient hadn't enrolled in a trial, which currently Medicaid is not compelled to pay for, which is different from any other payer. So there's a large advocacy effort within the organization and partnering with other professional and provider organizations to get behind this bill, which we're hoping will actually come to the floor in this Congress. And then we also do outreach to historically Black colleges and universities. The organization is very aware that we have a serious pipeline problem, that it is very difficult to deliver culturally humble and appropriate care to people when they are not represented within the provider population. And we have to get in early with promising students and trainees in order to explain to them why we'd love to have them in oncology. So we're trying to do that in a systematic way. And then once people are members of the organization, we are trying to direct a good bit of attention to diversity in leadership. So sort of the other end of what we think of as the pipeline. And we also focus on marginalized patients in categories like the elderly and rural patients, and have several efforts related to improving quality of care, both within specific marginalized communities through participation in two different granting programs, one from Susan G. Komen and one from the New Arcos Foundation, that essentially try to take quality programs that were designed previously by ASCO into communities and provider and health systems that serve minority patients. Because we realized in the organization about a decade ago is that we were designing lovely tools for the systems that already had the highest quality care. And they served primarily upper income and disproportionately white patients, while the programs were not being utilized by the health systems and practices that served disproportionately poor and minority patients. And these programs are designed to address that. And then our sister 501(c), the Conquer Cancer Foundation, which is the grant-making organization aligned with ASCO, has incorporated a focus on diversity into all of its granting programs, from medical student and medical resident awards on up through junior faculty and mid-career career development awards for researchers. So new things we're starting this year. We are coordinating with ACCC on a project to increase participation of racial and ethnic minority patients in cancer clinical trials. And we are also launching an educational effort that I'm really enjoying being part of, focused around the social determinants of health. And we decided that a good target audience for education on the social determinants of health was our fellows and junior faculty, who are still very much shaping how they practice and how they interact and communicate with patients. And so this is actually being launched as a podcast series featuring ASCO and other national leaders, and then later also patient voices, to talk about what the social determinants of health are, why you should care about them, how they're related to cancer outcomes, and actually how you get to know information about the social determinants for your patients in a respectful and mutual way that does not stereotype or make assumptions about people, but actually asks. I think the theme of just asking people has kind of grown through the day here, and that's part of what we're looking at. So we're very excited about that initiative as well. So I'm glad to take questions during the rest of the panel, and otherwise we can move on.
Thank you. I must say it is spectacular to see 3 women academics being very, very successful and making very positive contributions. I grew up in medicine at a time when women were not appreciated. I'm going to just say a couple of things about some of my work, and then we'll open it up to questions. People can submit their questions through the chat box. Much of what I've focused on, and actually the American Medical Association just day before yesterday issued a wonderful statement about race and racism. And they noted that race is frequently in medicine used as a proxy for genetics and a biological categorization, and that is wrong. Race is a social construct. As many people surmise from the talks that were given today, Black more likely means that you're not going to get adequate treatment. A higher proportion of Blacks get less than adequate treatment for cancer. I think that's true for Hispanics. It's also true, by the way, for poor whites. In some of my work, for example, in prostate cancer, we found that stage for stage, Black men with prostate cancer did the exact same in terms of outcomes as white men when treated at certain hospitals. Translated, equal care yields equal outcome amongst equal patients. Now, there were a higher proportion of Black men with prostate cancer, and the stages varied, but stage 3 Black, stage 3 white, same outcome if treated in the same hospital. Did that in terms of breast cancer as well. Found it wasn't quite exactly same outcomes, but it was hard to match women. And then we realized there's a huge problem in that a substantial proportion of Blacks in the United States with cancer get what I will refer to as less than optimal care, either because they can't afford it, the system doesn't want to give it to them. Sometimes it's just transportation issues, but whatever the reason, a substantial proportion of Blacks got less than optimal care. Then as we started looking into health equity, we found out it was a large proportion of Americans, not just Blacks, who got less than optimal care. And we then set out, and there are ways that you can calculate how well the health system could do. And we figured out that of the 600,000 Americans who will die of cancer this year, if every American got everything that college-educated Americans get, it would be 132,000 less. About 1 in 5 cancer deaths per year is the health disparity. And that, of that 132,000, by the way, 80,000 call themselves white. So the biggest health disparity population in the United States are white Americans. They tend to be poorer. They live in all 50 states. They tend to live more in the South than any place else. Ironically, they also live in states that have not expanded Medicaid such that people age 18 to 65 qualify for Medicaid under the Affordable Care Act. And what we're starting to realize is there's a growing state-by-state disparity. Massachusetts is doing very well, Mississippi, Alabama not doing very well. And so we have a long way to go in our effort to just try to get every human being adequate care. And being inspired by that Laurie Pierce slide, adequate care is prevention, it's screening, it's diagnosis, and it's treatment. So frequently we focus on adequate treatment, but we need to talk about prevention as well, smoking, diet. And I'll end with one last thing. I noticed energy balance and obesity was on the Laurie Pierce slide. One thing we have to remember is as smoking rates go down, smoking now the #1 cause of cancer in the United States, but as smoking rates go down over the next 5 to 10 years, it's estimated that energy imbalance, that is obesity, consuming too many calories, and not enough exercise. Think of it as a three-legged stool, not just obesity, but too many calories and not enough exercise. Energy imbalance is going to become the leading cause of cancer in the United States. And that's also a minority health issue. 60% of Black women are obese, and 80% of adult Black women are either obese or overweight. So we need to think about trying to get adequate care to everybody. I'll stop at that point. Are there any questions? Any questions from the panel? The ASCO initiatives appear to be hopeful, but what is the metric to determine if they're working, and what remedy will be employed to redirect efforts? That's a hard question.
It is a hard one. And I think as with every other quality assessment, there are process metrics and there are outcome metrics, right? And outcome metrics are always more challenging. So process metric wise, we set goals. We say, we want to implement this program in this many communities or this many states, and then we evaluate that. The Komen and NIARCOS quality programs in majority minority communities obviously have some pretty concrete metrics. So I think within segments, we can build that. I think as an organization that tries to push out education to providers, it's a little bit difficult to know when that's working in terms of its impact on patients and to measure it directly. We are putting a survey in the field right now to assess attitudes among members about issues related to equity. And I think that can and should be repeated to see if at least that process metric of attitudes among membership evolving over time and levels of knowledge going up is happening. I think to assess the impact on patients other than within, experimental programs like these grant programs is harder. For Conquer Cancer, when they make grants to trainees and junior faculty, they do then track the subsequent career development of those grantees. And I think that's one other way to see if the grant making programs are affecting success with folks in their later careers, whether they go on to attain academic positions, whether they stay in medicine and oncology, and what their personal successes are.
Thank you. Dr. Barrett, I'm sorry?
It's a very important question.
Thank you. Dr. Barrett, Dr. Sutton, you are non-physicians involved in health equity research, which is actually something when David Satcher first started talking about disparities in health and health disparities and health equity in the 1990s. I think he was dreaming that we would involve more than MDs, that this will become a multidisciplinary academic field. Speak a little bit to the need for diversity in the degrees of the people who are involved in this field.
Well, I guess I'll go first, especially since I'm not too far from earning my degree myself. So, you
have to point out that you're young, right? Okay.
No, that's not the same thing. But no, there definitely is a need for it. And, everyone here knows about the idea of the pipeline. And I think the problem is that we have not gotten that creative on how to engage individuals at younger ages. Like, you know, most of the work that I'm seeing now is like, oh, maybe undergrads or even some grad students and how to transition them on. But I'm starting to see work emerge, and this is very promising, on looking at like high school and even middle school students. And some work that I've heard recently was even elementary school students, and starting to shape their thinking with regard to STEM or science, research, even now with Disparities work. It is, you know, if you talk to Black faculty members, you know, they have their research, their service, their scholarship, and then they have this other thing where they're trying to mentor Black students. And I find myself in that position also. Just as a postdoc, I have many Black doctoral students that all gravitate towards me because there's not other individuals that they see that look like them that may be able to help them through the process. So not only for the patients and the participants that we interact with are there need to increase our diversity within the field, but also, you know, as a way to motivate other individuals that may look like you to even join the field in the first place.
Yeah.
Yes, I won't add much more to that. I think that was well said. I do think that, you know, I'm a medical sociologist by training. And what I love about the discipline, especially when I get together with others at the table, is that that's where I really see the richness of our thinking come together. Our interpretations of findings have little nuances that are actually different in our research work. How we pose our questions can sometimes be different as well. In fact, oftentimes when I'm thinking clinical versus medical sociologists come together. And what I find is that now that, particularly within my department and working in the cancer center, is that the more I see this interdisciplinary space, a multidisciplinary space, it actually makes a big impact on translational research. It makes a huge difference in the questions we're asking. And I'll just say this, just as you mentioned earlier, Dr. Brawley, this whole idea and this topic around this notion of biology being what we use to describe race instead of noting race as a social construct. Sociologists have been saying that since forever, since the beginning of time. So when I heard that people didn't understand that, and I was like, what? It was kind of a shock. I appreciate you saying that. As a sociologist, that's what we always are trained in. So we're brought up in that space of it's a social construct. It is not real. It is made up and is driven based on the economic and political climate and those who have power. Yeah. And so it is those types of pieces when we bring to the table around research, around ideas, and even as we see the next generation coming up, as they see more diversity in the teams, they start to actually leverage and reach out over to the social sciences and other areas to be able to make their work most effective.
Well, thank you for what you just said. Thank you so much. You know, in medicine, we so frequently equate race with genetics. I even have heard people talk about Black breast cancer as if it's a different disease. And for those in the audience, if one is triple negative breast cancer, I don't care if you're Black or white, the treatments are the same and the outcomes are the same if you get them from the right place. And by the way, I'll note real quick, there are 6 states in the country where there's no Black-white disparity in breast cancer mortality. And there are 11 states in the country where the death rate for white women with breast cancer is greater than the death rate for Black women in Massachusetts. You know, we have huge geographic issues with quality of care. We are coming up on the 15-minute warning, or a little less than 15 minutes now. Can I ask you, how has COVID affected your work, and what have you found to be successful in continuing your work and getting around COVID? And let's start it out with Dr. Reader Hayes.
Well, I spend a lot more time being an administrator than I did a year ago. I think perhaps I'm a natural optimist in that I hope that this experience for clinicians raises awareness about how broken our healthcare system is with regard to equity. With cancer, disparities take years sometimes to become obvious, right? From the time that a patient has screen detectable disease that maybe isn't detected to the time that a patient then dies of that cancer is years and years and years. With COVID, it's like we push the fast forward button, right? You can see immediately how differences in occupation, differences in who's an essential worker, differences in housing conditions, differences in access to care, ability to have childcare, social support are driving differences in incidence, and then also along with other factors like access to high quality care and comorbidities driving differences in mortality. So it's obviously a terrible thing to witness as a clinician and to try to help our patients through, but I hope that it's waking some of my colleagues up. So that's sort of how I see COVID at the intersection of being a clinician and being a disparities researcher.
Dr. Sutton?
Yeah, so for me and the team that I work with, it made us like wake up and I guess get into the 21st century. I mean, so many of our research protocols are actually quite antiquated, but we're used to what we're used to and we do what's comfortable. And I think now it's causing us to push the envelope and become a little more innovative. And so for instance, one study that I'm doing is a exercise and nutrition study for Black breast cancer survivors. And they were on site, they had a trainer that they worked with, they had a nutritionist that they met with, and then COVID happened and then everything stopped. And so my mentor was like, oh, okay, we need to figure out a way to keep that going. And, I'm thinking, oh, everyone's doing Zoom, she's like, we can go virtual, what can we do? And so it really challenged us to think beyond our traditional protocols, but then it also made everyone aware of this idea of the technology gap, because everyone wanted to shift so many things to online and virtual. And then we realized, especially with us, we work with a lot of individuals in the rural areas too, that everyone doesn't have equal access. So I think it's so many awful things have come as a result of COVID, but I think as researchers, it's making us think a little bit differently now about how we engage participants and how we develop our protocols.
Dr. Barrett?
Yes, I would agree. Most certainly making the pivot from in person to virtual was a big one for us, for sure. I'd also say it also helped me to really think about, what kinds of grants I could write and find out where people are. And so I actually have, we've been writing a lot of grants focusing on that, particularly around race, COVID-19, the social construct of race and COVID-19 and seeing how that plays out. The other thing that I find that's really interesting, though, is that with all that's been happening with COVID, and of course, I'd be remiss if I didn't mention the murder of George Floyd and other factors that kind of all culminated to this intense assessment around structural and systemic racism and even just systems and the way in which our systems are broken and how it highlights, I think, the points that we were doing around quality care. Then now it's making us start to step back a little bit and really look at our systems, look at our practices in our cancer center and in our hospital system, and where are the spaces in which bias may be happening that's totally unintentional, but the very policies are actually creating problems or challenges for our patients, and even for our colleagues actually too. So that, and then also recognizing that words matter. And so we're actually even starting to look more and more about the terminology we use, and how that may actually create more power differential in terms of the patient and provider interaction, and also how we interact with one another as peers and colleagues. And so I think that this is a lot of change that's come from COVID-19, but those are the ones in addition to the two that my colleagues already shared.
We only have a few more minutes. One person in the audience was asking, what kind of data should we be collecting to try to help understand social determinants of health? Any thoughts?
So I think the challenge for me there is that in terms of building, these elements into my own research is that, first of all, there are multiple levels, right? So depending on whether you're collecting data from patients or collecting data about a community or collecting data about a specific hospital, you want to measure different things. These are not often pieces of information that the healthcare system is financially incentivized to collect, right? You can always know insurance status because you can bet the hospital put that in the chart, right? But in terms of looking at, administrative kinds of data, maybe they care if the person smoked because that's on a quality metric somewhere, but do they care about understanding the person's social support? Do they care about data on the financial toxicity of their treatments, whether they've had job loss, occupational data? Many times, if we're not collecting it for research use, it's hard to find in the administrative data. And then, I think the other piece that we completely miss often is to study protective social determinants, right? So in communities where there's a lot of social deprivation, some individuals do well, right? Some individuals find a way, or their family finds a way, or their community finds a way to take good care of them. So I think I would like to see more measurement of potentially protective social determinants. And we also need much better research on how the social determinants, how social deprivation and chronic stress actually translates to biology as well. I mean, people are doing it, but I think they need to do it more.
I wish we could just get household income and education of the patient, but that's very difficult to get. I mean, many people won't give it to us if we ask, and it's not in your typical chart. Last thoughts from either Dr. Barrett or go ahead.
Oh, no. So one other thing I was saying that I think we definitely need to start to consider more zip code and census tract data. I think because we understand how important geography is, and even to like the zip code or the area of the city that someone lives in, you could tell a lot about the education that's there. You could tell a lot about whether or not it's a food desert or not. And so, especially with behavioral researchers, disparities researchers, starting to collect those data, I think will give us an idea more so of someone's social determinants and how it impacts their health.
Dr. Barrett, final thought?
Yes, I agree with both my colleagues again. Really well said on both parts, and I could not agree more. I'd like to kind of think about the question also in terms of how are we going to use it. And so we may be collecting those data, and we could probably create the best mechanisms to collect everything we want that might be useful. But my question is, how are we actually going to use those data to drive the clinical practice, drive quality care? What happens when we have all this information about our patients? Are we really going to move forward in addressing those determinants in any meaningful way? And how are we even going to use it to truly predict how best to give care to that patient? So those are the kinds of things that I ask also on that same end. Is one, as my colleague said, what should we be collecting? But the other side is how are we actually going to use it? And how are we going to measure it in a way that people are using it in the appropriate way to help our patients?
Okay. Last really quick question I think I can get in under the line here. Are any of you aware of a good resource that summarizes health disparities, health equity research findings? I mean, is it time to actually have a book?
Well, I think the closest thing we have right now was the AACR Disparities Progress Report that was just published in, I think it was September. It's a very comprehensive document. You can find it online. It summarizes disparities research that's been done. It summarizes the gaps. It summarizes where we're going with regard to equity. It's across all cancer types. It goes from prevention all the way through survivorship. And I think that's our best resource right now.
I think you're right. And I think that's a good point to end on. I want to thank Dr. Nadine Barrett from Duke, Dr. Arnethea Sutton from Virginia Commonwealth, and Dr. Katherine Reeder Hayes from the University of North Carolina at Chapel Hill.